We are recording. Ladies and gentlemen, boys and girls, let me present to you Tori Friedman.
Okay, hi y'all. Thank you so much for coming today. And I'm so excited to talk to you about postpartum depression, assessment, treatment, and clinical practice. I was laughing that I'm passionate about this, but I was joking that with my husband that y'all will probably be depressed after you listen to this if you weren't already from COVID, just because it's kind of a heavy topic. But yeah, so okay, so this is the training I just went to. This was Karen Kleiman, and she owns a postpartum stress center in Pennsylvania. And she's written dozens of books on the topic, and she's an expert in this field. And some of the books you can see she's written are Good Moms Have Scary Thoughts, Dropping Baby and Other Scary Thoughts, The Postpartum Husband, Practical Solutions, Therapy and the Postpartum Woman, and The Art of Holding in Therapy. So those are just a few of her books. When she was doing her thesis, she put an ad in the paper, I think it was like 20 or 30 years ago, wanting to do research for anyone that had experienced postpartum depression. And she had 3 people that came and talked to her, and 2 of these people were in their 70s. And she asked if they had ever talked to anyone before in their life about this, and they hadn't. So then that's where she felt compelled that there was a huge need for this research and helping women with going through postpartum depression. Let's see. So the training that I went to was called The Art of Holding Perinatal Women in Distress, Assessment, Treatment, and Advanced Clinical Practice. So it was a 12-hour training, and so I'm going to try to just, since I only have an hour, try to condense all the important parts of the training here today. So I'll start with my story. So I just wanted to give you a little bit about why I'm passionate about this subject. So I believe I suffered from postpartum depression probably off and on for 6 years after giving birth to my 3 boys. And so I suffered from mild depression and anxiety to more intense feelings of sadness and depression off and on for 6 years. And this was really hard for me because I'm an extrovert, and like I often didn't want to leave the house, and I didn't want to leave the house, and I'd have to push myself to go and do things, which was not like me. I'd never really suffered depression before, so this was all new for me. But what I didn't go to counseling, but I went to different doctors, and they would just kind of minimize it and tell me that, that's just normal. You have the baby blues, and I often felt really overwhelmed and shame because I think my whole life I looked forward to being a mom, and so this just kind of hit me. I was blindsided by this. So basically, I kind of felt just really overwhelmed by it all, and it really saddened me to my core. But I did have, however, lots of really happy times and lots of amazing moments, so it wasn't all really challenging. But let's see. So what did help me was going to like MOPS groups and mom-to-mom groups and church groups. And then I was in a Bible study. A woman started a Bible study when my son was 3 years old. And I'm still in that Bible study. And so God just really helped me increase my faith through all these challenging times. But I remember at my lowest points, there were times I just wanted to kind of disappear and run away to Mexico. I remember thinking that. But so what God taught me through all this is this, that just to rely on Him, and that God can. I love the verse Joel 2:22 that God will restore the years the locust has eaten. So so I just spent a lot of time praying and waiting on God. And probably 2 years after my third son, the depression just lifted. I woke up and I was just so grateful that that was gone and behind me. So so God taught me through all that to be transparent and content. And then I knew in my heart I wanted to help women suffering with postpartum depression. I want women to feel heard. I want them to know they're not alone and that they will and can get better. So here's a picture of my boys when they were little. So, and then
They're huge now.
yes, they're huge. I think two of them are 6'2" and 6'3", so it's crazy. So but yeah, so what is important for therapists to know? According to Karen, within the context of treating perinatal women in distress, wisdom is the balance between what you know and who you are. So and then, so it may be difficult for postpartum mother to reconcile needing therapy. How can that be when she has always wanted to be a mother? This hardly makes sense to her. Depressed women may withdraw and isolate themselves. Otherwise, intelligent women are grief-stricken and humiliated by their own thoughts. Okay, and let's see. Just trying to move my notes over. Okay, the principal feature that defines therapy with postpartum women, obvious yet often ignored, is that there is a baby involved. This is what distinguishes our work. Postpartum moms are hormonally compromised, sleep deprived, and besieged by demands placed upon them. So when sitting in the room with these mothers or our clients, the therapeutic energy feels especially urgent when we factor in the well-being of the infant. So time is of the essence. Here's a quote from the Yellow Wallpaper back in 1892 by Charlotte Perkins. Nobody would have believed what an effort it is to do what little I am able. So I remember just looking at laundry and dishes and just feeling like that was the hugest task in the world. Of course, I still have that sometimes, but anyway. Okay, so what is postpartum depression? Postpartum depression is an affective mood disorder presenting with symptoms similar to baby blues. However, symptoms of depression are more disruptive and persist beyond the first 2 weeks after delivery. Onset is usually with the first 3 months postpartum. It is not uncommon for women with postpartum depression to have, quote, comorbid symptoms such as panic attacks, obsessions, compulsions, or psychotic features. So onset is usually within the first 3 months postpartum. To an untrained eye, symptoms of postpartum depression can be difficult to distinguish from normal postpartum conditions associated with being a new mother. Symptoms which can emerge anytime during the first postpartum year might include insomnia, significant change in appetite, moderate to severe anxiety with scary obsessive thoughts, weepiness, feeling of inadequacy, irritability, anger, hopelessness, suicidal thoughts, difficulty functioning, difficulty concentrating, and loss of pleasure. And here's some of the predictors of postpartum depression. So prenatal depression is an indicator. Also childcare stress, life stress, poor social support, prenatal anxiety, poor marital relationship, history of previous depression, difficult infant temperament, maternity blues, single marital status, previous postpartum depression, severe menstrual syndrome, family history of depression, taking excessive sick leave during pregnancy, bereavement, and prior stillborn. So it should be noted that high number of women report feeling depressed during pregnancy, which is now believed to be a major risk factor for postpartum depression. So the prevalence of postpartum depression, it's estimated that 1 out of 7 women have depression in the year after they give birth, according to Weisner. In the lower socioeconomic areas, new mothers are twice as likely to develop depressive symptoms. So 1 out of 7, that's a big number. So some more predictors are difficult family relationships, work and stress, or a new job, severe financial difficulties, recent stressful events, victim of violence or abuse, low confidence as a parent, family history of postpartum depression, being a teen or adolescent, complicated or difficult pregnancy, thyroid problems or family history of thyroid problems, and oral contraceptive use or Depo-Provera shot soon after delivery, and or early or recent loss of a parent. So, okay, so the next one is baby blues. So these are considered a normal part of postpartum adjustment. The blues are understood to be related to hormonal shifts following delivery, affecting up to 5% of new mothers. Transient periods of sadness alternating with joy are typical. Other manifestations are frequent crying, anxiety, fatigue, and irritability. So the blues do not interfere with maternal functioning. If emotional vulnerability lasts beyond 2 to 3 weeks postpartum, it's not the blues. The blues are more self-limiting and require no treatment. Symptoms generally appear within 3 to 4 days after delivery, and they peak on the 7th postpartum day and remit spontaneously within 2 to 3 weeks. For most women, the blues are uneventful and fleeting. There is, however, some evidence that suggests that women who experience the blues are at risk for postpartum depression. And so a lot of physicians are still getting this wrong and calling postpartum depression the blues. So if it's after 3 weeks, it is not the blues. So, okay, then there's postpartum stress syndrome. This is another term for adjustment disorder. It presents when a mother struggles to get through the day with persistent distress, which does not resolve with reassurance or self-help measures. She may feel consumed by feelings of anxiety and self-doubt and feel pressure during this major life transition from external stressors or internal pressure to be the perfect mother who is in control at all times. If left unsupported, postpartum stress syndrome can lead to postpartum depression. And next we have generalized anxiety disorder. So this is marked by excessive worry. Women report feeling tense and irritable, nervous in social situations, feelings of impending doom, preoccupied with uncontrollable worries related to physical well-being of self and others, particularly the baby. Frequently, there is an increase in attention to physical symptoms such as nausea, shakiness, blurry vision, insomnia, fatigue, restlessness, racing heart, and shortness of breath. And I know these are a lot of definitions, but I think it's important to get these main ones. There's a lot more that I don't cover today. But so the obsessive compulsive disorder or postpartum OCD, it's characterized by obsessive intrusive thoughts, images, or urges, which may or may not be accompanied by compulsive behaviors. These unwanted thoughts appear out of nowhere, and they are highly distressing. While women understand that they are actions taken in response to these thoughts would be wrong. They are extremely agitated by the thoughts and worry that they may actually act on them. Postpartum anxiety is measured by the degree to which it interferes with a woman's ability to function and get through the day and how much distress it causes her. So, post traumatic stress disorder is an anxiety disorder which can follow an experience involving threatened or actual serious injury or death to the mother or her infant. Witnessing an event involving death and reacting with horror or feelings of helplessness contribute to the definition of trauma. Women who experience trauma related to childbirth might experience nightmares, flashbacks, anger, or difficulty sleeping and or concentrating. And panic disorder postpartum manifests as distinct periods of intense fear and typically involves palpitations, sweating, chest pain, shortness of breath, dizziness, lightheadedness, numbness, fear of dying, and losing control. Most of the time, panic involves catastrophic misinterpretation of bodily sensation. And then there's bipolar disorder. During the postpartum period and the pregnancy is characterized by periods of extreme highs and extreme lows. During pregnancy and postpartum, it can be difficult to diagnose bipolar, which can be confused with unipolar major depressive disorder unless careful history of mood, sleep, and activity levels is collected. Bipolar 1 is primarily distinguished by the presence of manic episodes, while bipolar 2 is characterized by hypomanic episodes. So women with a history of bipolar are at an increased risk of experiencing an episode during pregnancy and postpartum and should be carefully monitored. They are also at risk for postpartum psychosis. So postpartum psychosis is the least common but most serious postpartum mood disorder. It affects 1 to 2 per 1,000 deliveries, typically appears within the first month after delivery. The presence of the psychotic symptoms such as delusions, hallucinations, often involving the infant, avoidance of the infant, loss of touch with reality, extreme agitation, confusion, and inability to sleep for several nights, significant irritability, racing thoughts, rapid speech, rapid mood swings, paranoia, with suicidal and or infanticidal thoughts, necessities aggressive medical treatment, and most likely hospitalization. So psychosis, again, is associated with bipolar disorder. So if your client has a history of bipolar, they should be carefully assessed. Okay. So next we'll talk about what is our job as a clinician. Does anyone have questions before I jump into this? Or I know I said a lot about a lot of definitions. So the next section is what is our job as a clinician? Meet the client where she is at and tell her that she is safe. Our job is to determine the symptoms of intensity, frequency, and duration of her symptoms she's having. Our job is also to let her know that she's not alone and that she's come to the right place. Let her know that this feels terrible and that she is sick right now, but she will get better. And when you feel better, you will not feel like this anymore. And then also point out her strengths. And then determine how much she's crying. If she's crying too much, your job is to tell her when it is too much crying. Be with her and be willing to sit with her in her suffering. Lean in and give her eye contact. Let her know that she's not alone and that you're there to help her and you can help. Okay. So unique postpartum specific symptoms are ruminating obsessions, unpredictability, client and clinician, guilt, feelings of inadequacy, insomnia. Women report difficulty sleeping and even when the baby sleeps, persistent and persuasive anxiety, and negative intrusive thoughts about the infant and safety. Um, so Karen mentioned that if as a clinician, kind of if you're not getting anything from your client or you're not feeling anything, that is kind of usually an indicator that there's something way more going on. And she's probably suffering from postpartum. Let's see. So predominant beliefs based on depressive response. Often the mother will say, I'm a bad mother. Everything is out of my control. I am weak and dependent on others. I will always feel this way. My loved ones will abandon me. I am powerless over how I feel. My environment is unsafe, unpredictable, and lacking in meaning. So it's important here to point out that like little victories she's having, like if she's having 5 hours of sleep instead of 3 or 2 meals instead of 1, just keep pointing out the positives that are happening. Next, we have something called scary thoughts. Almost 2/3 of women who screened positive for depression had comorbid anxiety disorders. Clinicians need to know that the most common clinical presentation is in the post-birth period is more complex than a single episode of depression. The depression is recurrent and superimposed on anxiety disorder. Okay, so now I have a video, and this is a woman suffering from postpartum OCD. So let me, hopefully I can get this playing. Let me see where we're at.
One thing I might say, Tori, as you upload the video, play it and see if we can hear it. But Teresa had issues when using her earbuds. It would
okay.
be back in her ear, but we couldn't see it. And it was, in theory, it would be helpful if you took out your earbuds and then we would hear at least the play through your own speakers, if that makes sense.
Okay, so I'll try it first, and if not,
Yeah.
I'll unplug it. Let's see. So, whoops. Okay. Okay, wait. So I think I have to, okay. Share this tab. And then.
We can definitely see it.
Can you hear it or not yet?
Yep, we can hear it.
Okay.
There's no avoiding this illness, because for me, it just kept getting harder and harder and worse and worse. I just remember the first time when I was driving, I had an incident with this white plastic bag. I saw it on the side of the road and I thought it was something. Like my brain was telling me, what if it was a baby in a bag? What if I hit it? And what ifs just kept running through my head. So I'd circle back and check on it. And then I'd circle back again. And it took me 45 minutes to get off that road. I chalked it up to hormones or the thought of maybe it's just because I'm going to be a mom and I'm nervous about things. And then from that point on, driving was really complicated. It was all the actions that I did that equated to my condition. It took me 40 minutes to shower. Why? I had to, but I had to make sure I was clean. And every time I tried to get out of the shower, I had to get back in again. And then I kept saying, well, I can't touch the baby if I have dirt on me. And so then I would get back in again, and then I would come back out, and then I had to get back in again. And so 40 minutes later, I just took 40 minutes to shower. And to be honest, never really felt perfectly clean for her. And so all the little things that somebody would do on a day-to-day basis now took so much energy for me to do. My husband and I both fed Alex, and the one time he was cleaning something with cleaning product, just something in the kitchen, something basic, a kitchen cleaner or whatever. And he washed his hands, and then he was going out, so he said he would make up Alex's bottle, and that's fine, that sounds great. So he made up her bottle, and then all I kept thinking was, he didn't wash his hands well enough. And I kept saying, did you wash your hands? And he'd say, yes. And then I'd say, I don't know, did you wash your hands? And I would think I repeated it like, I don't know, 10 times. And then I kept saying, what if the cleaning product got into the bottle? What if the chemicals in there and we make her sick? And it got to the point where I was sitting there holding her and about to feed her, and I couldn't do it. I was literally paralyzed because all I kept thinking was, I'm gonna poison my baby. And she's gonna die, and all because he didn't wash his hands right. Which just all sounds so ridiculous, but that's how I felt. And he had to go, so he's like, are you all right? And I said, I guess I'm fine. And then he left. But that feeding her was excruciating because all I kept thinking was, oh my God, I can't believe I'm giving her this bottle. Like, how could I possibly do that? From that point on, every time I made a bottle, it was so painful because I had put this idea in my head that I could possibly poison her with something. I couldn't sleep all night. This is something that had gotten worse, which is surprising because I felt like I had actually said something and I was going to get help, but something had gotten worse in just a matter of a half of a day. And I stayed up all night. And then the next morning, I said to my husband, well, you can't go to work today. I can't be left alone. My dad was coming over to help me, to take me to the appointment. And then at that moment when he came in, he gave me a hug, and very quietly, I just said, I just didn't think that I belonged here anymore. That maybe it would just be better if I wasn't here. Sitting there waiting to get my appointment, and I walk in and I meet the counselor, and she looked at me and she said, and she gave me a hug and she just said, I know what you have and you're gonna be okay. For some reason, I felt like I could believe that. And then she gave me this checklist of OCD tendencies. And for the very first time knew what I had, because everything on that piece of paper was what I had been doing and all the things that I had feared. And it was like, oh God, it was the first time I could breathe. I could just breathe because someone told me what I had. Someone told me I would be okay. And I felt like I could have hope again. You know, you do get beyond it all. You get beyond the fear, you get beyond the anxiety, but you can't do it unless you get help, unless you really find support and amazing people who are out there doing it every day and available to you.
Okay. Can y'all hear me? Whoops.
Yep.
Oh, now you can hear me. Yes. Okay. So there is no correlation between a mother's scary thoughts and her taking any action in response to these thoughts. So the scary thoughts are on a continuum. It can go from just as little as just having some scary thoughts to all the way up to horrible thoughts of like hurting the children or hurting the child. Whoops. Okay. Sorry, I'm trying to pull my notes over. Let's see. Okay. Does anyone have any questions on any of that or the video? Okay. Okay. So next we have thoughts, OCD versus psychosis. Both can involve violent thoughts. The OCD mom is terrified that the harm may occur, but she will still try to resist obsessional thoughts. But the psychosis thoughts are perceived as consistent with her character or her worldview. Thus, she does not resist the thoughts. Thoughts are part of the delusions and accompanied by loose associations, irrational beliefs, and behaviors. So OCD would be more like the woman in the video, and then the psychosis would be like, if y'all remember the Andrea Yates story, the horrible story where she drowned her kids in the bathtub. No relations to Charles Yates.
I have a question.
Okay. Yes.
What is the connection between this and the mothers who have lost the baby after birth? Because they're obviously going through a different kind of thing. There's also grief involved, but
Right.
the chemicals might be similar because they're going through all the same stuff and they can't nurse. How do we think about that?
Well, I think that would fall in the postpartum stress, the trauma. What am I trying to say? What we talked about earlier, but just with the trauma, like PTSD. But I think if left untreated, that can move into postpartum depression.
Well, there's always those stories, and we've talked about it commonly, like women who lose a baby will hear a baby crying in the other room, even though there is no baby. That
Right.
definitely is going into some of the psychosis piece. I'm wondering if that entered into any of this training.
She just barely touched on that. So just that it's real important to assess every detail so it doesn't, evolve more into postpartum depression. But I guess you would treat the trauma, in that case and just help her with that. But yeah, there's so much more to this and I just tapped the surface. So, but that's a good question. I can find out more too for you. Okay, so did you have any other questions, Vanessa, or on that?
No, that was it.
Okay. Okay, this next section, what will help for a mother going through this? Distraction, breathing, relaxation, mindfulness, self, which is sleep, exercise, laughter, and food. Just making sure just the basics are really covered are so important, because a mother in this one of these states, it's really hard just to just normal basic tasks are extremely difficult. Journaling and support groups are really vital. So when do we need to refer our clients to emergency room? We need to refer them when the mother states she's afraid and might harm herself in order to escape this pain, and she has a plan. Or when a mother is afraid she might actually do something to hurt her baby, or when she feels that her thoughts are not her own or that they are totally out of her control. Also, if there's signs or symptoms of mania or psychosis, or a mother states she has not slept at all in 48 hours or more, or when a mother does not feel loving towards her baby and can't even go through the motions to take care of him or her, and then any major functional impairment. So, and here's some risk factors of psychosis. Some women have no history and no warning. Other women have a history of bipolar disorder or a previous psychotic episode, or they have a family history of psychosis. And then research states that 5% of suicide rate and 4% of infanticide rate are associated with postpartum psychosis. And then we need to talk about suicide. So you want to make sure you do a suicide assessment and do a detailed history. It's important to see if they have access to guns, knives, and ask them other difficult questions. And then how passive is passive? Are they always this passive? How were they prior to birth? And when do we worry? And barriers to suicide, and determine how to keep her and the baby safe, and always involve members when concerned. Family members. So according to Karen, we're supposed to presume that everyone is potentially has suicide ideation. And if you don't ask, you have no idea. And if you ask, you still may not know. They still may not tell you. So you really have to lean in and really figure out who your client is. Tease out their distorted thoughts, and because she said it can happen so fast. And a postpartum depression client can turn on a dime. And there was a research study done in Australia that showed that those that committed suicide and those who were successful, they were asked a few months prior and they denied having suicide ideation. So it is safe to say that new moms do not want to die, but it can turn on a second, and they can get better in a second, and they can get worse in a second. So it's important to keep assessing and keep asking and leaning in. And it's important if she's at that point to talk about if she successfully killed herself, that the baby will never be okay, that the baby needs her. And it's really important that you help them to heal and let her know she's not alone, and that there's so many options, and that she feels horrible right now, but that you're there to help, and she will get better, and she can get better and will get better. You're just not sure when. So, but you're there to be with her through the whole process. Okay. So it says to keep an eye out for trust your instincts. And then if something doesn't feel right, it probably isn't right. And be mindful of countertransference issues you may have. And do not be fooled or misguided by how good the mom or how the mother looks or how she sounds. And do not underestimate the power of pretense. So, and then, whoops. So medications, a lot of women choose not to take medications when they're pregnant or postpartum, even despite the studies that support that women have major relapse if they get off their antidepressant medicine. So it says that clinicians should keep this in mind, and the data supports evidence that the toxicity of women using antidepressants while breastfeeding are extremely sparse. So overall, they're saying that it's better to keep a woman with depression or one of these other major disorders on their medicine. So holding is a technique that with perinatal women, it's a strength-based approach. It's meeting the woman where she's at. It's not giving her solutions too quickly. It's like sitting with her in her distress and not moving forward too quickly, giving her solutions already, just sitting with her in her discomfort until she's ready to move to the next step. So it's important with holding to do some grounding techniques. This is where you let her know she's safe and she came to the right place. Tell her to actually put her feet on the ground and use your words and your voice and validation. Karen talked about using their names a lot and just really using your empathy skills and just being really present. And you're supposed to present as the expert. You never tell them you're the expert, but just present as the expert and come across that you know that you're going to get through this together, and let them know that you can tolerate the distress and you want to do reflection and it's also, I already kind of touched on this, important not to rush through and give the mother solutions before she's ready. Just help her sit in her distress and let her know it's painful, but she will feel better. And you're not sure when, but she will get better. And together you can get there. Let's see. Can you hold in the highest level of distress? So as a therapist, are you sure you can sit with the discomfort, figure out your biases, be willing to bear the unbearable, help her tolerate her discomfort? Are you able to tolerate the discomfort? Sometimes it means doing nothing. So this is what I was talking about. Resist the urge to problem solve, which may reflect your attempt to avoid feelings of helpless. And then we're to avoid contrived or excessive sympathy, avoid coming across too parental, which could patronize and insult, and always balance her pain with your hopefulness and her suffering with her strengths. And then cultural influences. Some cultural traditions have mixed impacts on postpartum depression. So like some cultures mandate a new mother rest for a month while extended family provides practical support. And this may help physically, but it may also increase her mental conflict. We're to consider all the cultural traditions and how they impact the mother. Some holding responses need to accommodate cultural expectations, like eye contact, touching, and your posture. And when in doubt, ask her what she's comfortable with, if there's cultural things to take into consideration. The postpartum husband. So when we talk about the husband, make sure that see if he's providing support. Is he a facilitator or saboteur? Is he? You want to use the couple to understand vulnerable areas and facilitate healing in those areas. You want to keep the husband in the loop, keeping him healthy. And half of men who have partners with postpartum depression will develop depression themselves. So 1 in 10 men experience depression, which is pretty high also, after the birth of the baby. Karen mentioned that a lot of people, a lot of men, once the woman starts healing, the man will start going backwards because he had to hold it together the whole time for the mom that was suffering. Now he starts dealing with his depression. So make sure to meet the husband and the baby at least once. Do not forget to ask if she's medicating with drugs and alcohol, if she's having trouble sleeping. Does she think passive suicidal thoughts are okay? Does she have weapons in her house? Has she told her partner how bad she feels? Is she keeping any secrets from anyone or everyone? And is anyone scaring her about the way she feels? Some more tools that help. Listen to her voice of depression, allowing her, tolerating dependence and vulnerability, know who she is and what she needs, empowerment, and this was a big one that Karen kept talking about, is believe in your ability to help her. And then all of these are just little tools she uses. Because of time, I'll just talk about the butterfly one. Just trying to relate to her that, when we go through pain, that it's like a caterpillar and then the cocoon. And then once you get through this, you'll evolve into a butterfly, and you will get through this. So, and then another question, important question to ask, what was her relationship with her mother? Expectation of what kind of mother this mother will be. Was your mother the same or different? Was it haunting for her? Was it impacting her? So you want to find out all the good, bad, and ugly, all the things she's feeling about her relationship with her mother. For the therapist, it's important to, when you're working with a lot of these clients, to have self-compassion, identify areas that you're suffering in, avoid burnout, compassion fatigue, vicarious trauma. Make sure you're getting your own therapy when you're working with these clients. And what are your warning signs if you start getting extremely overwhelmed? Okay. So there's a lot here on the impact of COVID-19 on reproductive psychiatry. There's just so many things to consider. Women are waiting to decide if they want to get pregnant because they're worried about contacting COVID or being in hospitals or going to hospital and being left behind if they had COVID and having to leave the baby at home. There's just so many things to consider during this pandemic. And then also going to the doctor pre and postnatal. Women may go to the doctor less often because they're scared to contact COVID. It's just important that they're following up with their doctor online and getting the care they need prior and after they deliver. And there's also the risk of social isolation during the pandemic, and it can become even worse if they have any of these symptoms. And you want to make sure, because the older generation, the family that usually comes and helps, they may not have this extra help. So just important to consider all these things that are occurring with the pandemic going on. Okay, so tips for professional and family support. So again, do not assume that if she looks good, she's fine. Do not tell her it's normal to feel this way after having a baby. Do encourage her to get comprehensive evaluation. Do not assume this will get better on its own. Do encourage her to get a comprehensive evaluation, and do take her concerns seriously. Do let her know you are there if she needs you and that you take her concerns seriously. Okay, and this is for physicians and other healthcare practitioners. So if they're not asking these questions, you don't know how she's feeling. Have you had postpartum depression before? Do you have a history of depression? Are you sleeping okay when your baby sleeps? Have there been any changes in appetite? Are you experiencing anxiety or panic? Are you afraid to be alone with your baby, or do you feel more irritable or angry than usual? So, and then also, are you worried about the way you feel right now? And what worries you the most about the way you feel? Are you afraid you might lose control? Are you afraid of the thoughts you are having? And do you wonder if you're a bad mother? If you're breastfeeding, how important is that to you? And do you have thoughts about hurting yourself? Do you find it hard to make decisions? And does your husband know how you're feeling? And how do you feel about taking medication? And are there any other stressful events impacting your life that we should know? Okay, so that is kind of everything. Just the most important thing is to remember is always to balance her pain with your hopefulness and her suffering with her strengths. Okay, so I have some important websites you can look up, and if you need extra information, and then these references. So that is it. I'm going to send y'all some assessment tools. I'm going to email them to you. And there's 3, and there's a suicide assessment for postpartum women also. So I'm going to send you 3 different forms in an email. But do y'all have any other questions at this time? Thank y'all for coming.
Good work.
Tori, that was awesome.
Thank you. It's kind of
Is this
heavy.
going to be available? Do we have a way to get this information?
Yeah, I have all these slides on, it's on our Google Slides account.
Are you breaking up? Sorry.
Oh, I have all these slides on the Google Slides account. I saw that, I think that's for our work where I have them. But if they're not, I'll get them to you. So all these slides are there, and then I'll email these assessment forms to everyone.
Oh yeah, that's great. Good stuff. Thanks.
Okay, thank you.
Hey Tori. Hey Tori, on that, there we go. On the self, what did the S and the E stand for?
Let me go back. Oh, it is. Oh no, that's not it. Sleep. It's sleep. Food. Oh, now I'm forgetting. Sorry.
You said laughter and food were the last.
Oh yes, sleep, exercise, laughter, and food.
Okay.
Yes.
Awesome.
Okay.
Tori, are you waiting for me to break in?
Oh yeah, I don't know. Yes, I guess.
Awesome. Tori, thank you so much.
Okay, you're welcome. Thank y'all so much. I know it was a lot of information, so if you need anything else, let me know, and I can find it for y'all.
No,
Thank you,
that was
thank you,
great,
thank you.
Tori. Yeah, that was probably the most information. Very helpful. You might be the winner of all of them.
Well, good. Well, thank y'all so much.
Yep.
Y'all have a great day.
You too.
Bye.
Okay, bye.